Rock and roll.
So this is based off, almost exactly off the Academy Review book chapter on cervical spine degenerative conditions. So should follow nearly everything in the review chapter. So we'll start off with axial neck pain, go to radiculopathy, and then talk about myelopathy in that order. So we'll talk about who it happens to, how often happens, talk about neck pain, arm pain, and myelopathy. So kind of the basic degenerative disc disease. Everyone knows this. It's common. It's spondylosis, also called arthritis, also called degenerative disc disease. I think that's one of the challenges that we have with patients is we have the same condition called about 10 different things. The pathogenesis of degenerative disc disease, and this is more basic science for OIT and board review. You have an increase in keratan sulfate and a decrease in chondroitin sulfate. The stages of disc degeneration seen on the right here are first disc dehydration, which results in decreased hydrostatic pressure, therefore decreased height. You lose disc height, abnormal segmentation motion, osteophyte formation, and then in the back you get ligamentum buckling and hypertrophy and facet arthrosis, and that's what causes the stenosis is a combination of the encroachment from the anterior of disc degeneration and osteophyte formation and posterior from ligamentum flavum hypertrophy and facet arthrosis. So axial neck pain, very similar to midline axial low back pain. It's very common. All of us get some episodes of varying degree of neck pain throughout our life, but they're usually episodic, they're self-limiting, they're rarely severe, rarely need surgical intervention. It's often exacerbated with extension because that motion loads the facets, similar to lumbar spine pain.
Yeah, Adam.
Yeah.
Your volume's coming in and out pretty, it's kind of like pretty intermittent as far as your volume.
Okay.
I don't know if everybody else is hearing that too, but I'm hearing that on two separate phones.
I'm sure they are. Hold on, let me see here.
It's just it's your speaker.
Yeah.
Frank, were you hearing that too, Frank?
Yeah, I am.
It could just be where your speaker's located on your computer.
Yeah, I have to do kind of a hybrid of my son's gaming headphones and my. Hold on one second.
I'd actually prefer to watch you play some game.
Yeah, I can play some. What is it called? Fortnite. Hold on one second. Let me try to stop that. This stupidness. Let me see here. I'll try to stop the video of me and just use the headphones.
Can you dial in? Can you use the audio from a phone?
All right. Can you guys hear me better now?
That's much better.
Okay. All right. I just won't turn the camera on because you'll see me with giant gaming headphones on, which might be worth it.
Thanks, Adam.
For comedic value. All right, let me turn this back on here. Thanks for letting me know. You guys can hear me fine now?
Oh yeah, now we can really hear you.
Okay. Yeah, nothing but the finest gaming headphones for my son. All right, so imaging here on the AP, you can see the disc, which is this portion right here. There's these lateral extensions that rise cranially and laterally called the uncovertebral joints. They're not true joints. They're more extensions of the disc space. If you guys ever see us do ACDFs, we'll clean out the central portion, the horizontal or transverse portion of the disc, and then work up and out into the uncovertebral joints. Because the most lateral extent of the uncovertebral joints subtends or bounds the cervical neuroforaminus. So if you get hypertrophy of these joints, it can block the nerve tunnel here. But that's one of the findings on x-rays. Not only do you get kind of a fuzzy view of the facets, so these are the facets here, and osteophytosis or facet arthropathy here, but you can get uncovertebral spurring as well. On the lateral image, you can have loss or reversal of cervical lordosis with degenerative disc disease. Similar to the lumbar spine, you have disc height loss and arthritis, and since you lose that portion of the anterior column, you get collapse there with relative preservation of the posterior column and the facet. So you have kind of this anterior sag causing cervical kyphosis. Flexion extension views have value to show dynamic instability. So I think it's important to note when you're speaking about the spine, there's spondylolisthesis, which is translation of one vertebra on the other, either in the coronal or sagittal plane. So that does not speak to dynamic instability. So you can have a fixed anterior listhesis that doesn't move. So perhaps here you have a grade 1 anterior listhesis of C5 on 6, but when on flexion, it may not move. This one moves a little bit, but you can see. So this person has dynamic instability of C3 on 4, 4 on 5, and 5 on 6 that partially reduces on extension. So flexion extension views are good for bringing out dynamic instability. Oh, sorry, I went backwards. An open mouth odontoid view, we don't get them a whole lot except sometimes to look for odontoid or dens fractures, but you can sometimes see joint space narrowing between the lateral mass of C1, which is right here, and the facet of C2. And you can see C1 and C2 have much different anatomy than does the subaxial cervical spine. So the joints of C1-2 are actually anterior, whereas the joints of the subaxial cervical spine are posterior. So it's always important to kind of think about how those joints are different. So if someone comes in with neck pain, obviously you want to make sure they haven't had a recent trauma, want to make sure they have no red flags. So the standard fevers, chills, recent unintended weight loss, cancer history, pain, weakness of the upper and lower extremities. So someone comes in, severe neck pain, maybe they have a history of IV drug use, they don't look well, you always want to make certain they don't have a brewing infection. So these are all the things that we kind of talked about here. Just make sure no red flags. Treatment, most of the time it's encouragement and education. So letting people know that it's episodic, it'll improve. People can do some gentle range of motion, kind of active or active assisted range of motion exercises, cervical spine, do some stretching. Also can be beneficial is short course of non-steroidal anti-inflammatories, also with severe pain, short course of oral steroids is an option, certainly not without possible complications, but usually well tolerated. And then surgical, we very, very rarely offer surgical intervention for axial neck pain due to degenerative disc disease or spondylosis. There is some published reports that show favorable outcomes with posterior C1-2 fusion for atlantoaxial arthritis. So I think I've done that with maybe a grand total of 1 patient. People with C1-2 arthritis can also get greater occipital neuralgia or irritation of the C2 nerve causing posterior occipital headache. So that's something to keep in mind as well. Oh, there you go. See, I know my talk. Going ahead without even knowing it. So always think of C1-2 arthritis, look on the lateral view, any joint space loss or osteophyte formation between the anterior aspect of the dens and the posterior aspect of the front of the C1 ring. So it usually happens in old people. They'll usually say that whenever they turn to hear someone talk, their rotation is not only restricted, but causes severe high head pain or neck pain. People say it feels like it's in between their ears. Oftentimes people get greater occipital neuralgia and have C2 distribution pain, so occipital headaches. Much worse in rotation than with sagittal plane motion, because remember, you get 50% of your rotation from the C12 joint, 50% of your flexion extension from the occipitocervical junction, and then the remaining 50% of all plane motion is in the subaxial spine. So it's another commonly tested question. Axial neck pain is pretty straightforward. I think the only thing they would ask you on the test is, you know, they show a terrible neck and they'll say, what's the initial treatment? Or they'll give some benign exam. They'll say, what's the initial treatment? It's almost always non-operative. Or they'll give you a case that just looks like disc degeneration, but it'll be an IV drug user with fevers and chills, and the answer will be get an MRI to rule out a cervical epidural abscess or spondylolisthesis, something like that. Always want to be careful too, just speaking about neck pain and red flags, anyone with ankylosing spondylitis or a dish spine, so a rigid cervical spine, any low-level trauma. So an old patient that says, oh, I just, you know, laid down on the bed awkwardly and kind of fell, and now my neck hurts like crazy. So even low-level mechanisms in the setting of osteopenia or osteoporosis with a rigidly fused spine can have an occult fracture, and fractures in ank spawn or dish can be very subtle, particularly on x-ray, and can be wildly unstable. So those are the patients that you get an x-ray, their spine looks like a dish spine, but you don't see anything. You let them go home, they come back paralyzed because they had a 3-column crack that went the whole way through and it displaced. So you always want to have a really, really heightened, you know, keep your antenna, your radar up for ank spawn or dish patients. So now we'll talk about cervical radiculopathy. Cervical radiculopathy is compression or irritation of the cervical nerve root resulting in shoulder or arm pain, fairly straightforward. This is a common axial T2 weighted MRI cut through the level of the disc. The foramen are always oriented ventrally and anteriorly, so the cord is here, the roots come out almost immediately. It's not like the lumbar spine where they have a traversing portion and an exiting portion. All the roots are exiting portions. It's important for numbering. So if this is the C5-6 disc here, it encroaches where the C6 nerve exits. Always remember, it's a silly detail, but on axial images, patients' feet are coming out towards you and their head and body are back behind you. So, you know, for the more junior guys, this is the left side, this is the right side. The nerve root always lays dorsally to the vertebral artery. At the level of disc, the vertebral artery is not in a transverse frame and it's just free floating. So you can imagine as you come in here and start to do a discectomy, you work back to the posterior annulus and the posterior longitudinal ligament, resect that. As you're marching here, as you continue to decompress, this is the uncovertebral joint here, the vertebral artery is at risk. So it's relatively uncommon to get a vertebral artery injury doing a discectomy, not unheard of, but it can happen. Vertebral artery injury is much more common doing a vertebrectomy or a corpectomy. So you can imagine if we shift this down a few millimeters to the level where this is vertebral body and there's a transverse frame in here, the most common mechanism, and this is, I've seen this tested before, is using a high-speed burr, and you're burring out and you're not central and up and down, and you come and get into the frame and get a vertebral artery injury. So the question will be, you know, what's the most common mechanism for vertebral artery injury during anterior cervical spine surgery? And the answer is use of high-speed burr. So two different kind of etiologies of cervical radiculopathy that we see. They tend to be bimodal in their age distribution. Younger patients get a soft acute disc herniation. So same mechanism as the lumbar spine. There's a failure of the containment, so that the hoop stresses blow out the annulus and oftentimes the posterior longitudinal ligament, and soft disc or nucleus pulposus material will escape and encroach on the entry zone of the neuroforamina. The posterior longitudinal ligament is pretty stout. That's why most disc herniations are off to one side or the other, and less commonly central. Not that they can't happen centrally, but usually kind of get over to one side or the other, and it's the same in the lumbar spine as well. The other mechanism is what's called a hard disc herniation, which is not really a hard disc herniation, it's really a spondylosis. So this is a really nice cut. It's an oblique cut whereby you see the disc here. This is the upsweep of the uncovertebral joint. You can see how, even though we call it the uncovertebral joint, it's really just a continuous extension of the disc. And this is the facet, the inferior articular facet, superior articular facet here. They're shingled. There's no pars interarticularis in the subaxial cervical spine. If there were, it would be kind of this line of bone right here, but there's not. There's a lateral mass. So lateral mass is composed of superior and inferior articular facet. So the foramen is subtended by the pedicle above, the pedicle below, the facets in the back, and the uncovertebral joint ventrally. So if you get an uncovertebral hypertrophy or osteophyte, it encroaches on the foramen here. If you get facet hypertrophy, it encroaches in the foramen posteriorly. So evaluation, obviously you want to be able to do a good myotomal strength exam, knowing all strength major muscle groups from C5 down to T1. You want to know dermatomal distribution, common reflexes. I find it hard to determine radiculopathy in the high cervical spine, so C2, C3, and C4. C2 is a little bit easier because it's occipital. C3 and C4 are commonly kind of the cervical cape, so over the anterior clavicle or side of the neck. So it's not that people don't get radiculopathy there, it's just a little bit more tough to diagnose. The most common levels of degeneration, and thereby the most common levels of radiculopathy, is C5-6 is the most common level degenerated, followed by C6-7, followed by C4-5. So you can see those are all the nerves that correspond to each of those levels respectively that I just spoke of. So the absence of a dermatomal pattern does not rule out cervical radiculopathy. In fact, there's been a couple recent studies shown that the fidelity of physical examination and determination of dermatomal patterns not great. So it's probably about 70% that everyone C6 is the same and presents the same. So it's what Shen's always said, that he doesn't believe in dermatome, so maybe he was smarter than all of us. So it can also present as trapezial. I've also often tell you guys when you're with me, always beware of parascapular pain. I found that low cervical radiculopathy, so C7, more particularly C8, very commonly has intense medial border of the scapular, periscapular pain. And this is just what we talked about, so know your netters about where each one of these nerve roots go. Obviously, they combine in the brachial plexus, so a lot of these dermatomes also represent some portion of peripheral nerves, so you should kind of understand that, you know, C5 looks like and turns into the axillary nerve. So you can really bring in cervical spine surgery, understand how it goes through the brachial plexus, and turn it into hand surgery. I mean, you should really kind of understand, because it helps you with physical examination. And also in clinic, we find a lot of carpal tunnel, cubital tunnel, find some thoracic outlet syndrome, and also find shoulder pathology. So really, if you're going to be a spine surgeon, shoulder or sports surgeon, or a hand surgeon, it's good to kind of know all the fields well, because oftentimes someone will be in clinic saying it's my shoulder, and really it's a C5 radic. So you guys should just know this chart. C5 is deltoid weakness. It's the patch of skin over the lateral shoulder. C6 radiates into the thumb and index finger. So, you know, kind of the trick is, remember, turn your finger into a gun and 6-shooter, and that's where C6 is. It tends to be biceps and wrist extension. Biceps has a bit of an overlap with 5, so wrist extension is a little bit more pure 6. C7 goes into the long or middle finger, wrist flexion or triceps. Triceps is pretty good because it's also the reflex. C8 is finger flexors, so have them kind of grab your fingers with theirs and try to peel your fingers open. That's a pretty good C8. And then T1 to hand intrinsics. And remember, the C8 nerve is the goofy one that comes out between C7 and T1. So this is what we talked about, knowing which nerve exits out of which level. So cranial nerves exit above their corresponding number pedicles. So C8 exits between C5 and C6. So a posterior lateral disc herniation gets, so there's no traversing nerve root, it's just an exiting nerve root, unlike the lumbar spine. So C5-6 gets a C6 nerve. Pain over the radial forearm and radial 2 digits of the hand, weakness of wrist extension and biceps, blunted biceps and brachioradialis reflex. So you guys should just know all those. So sensory evaluation, one function of the dorsal column, so light touch, and then you can do pinprick for spinal thalamic. So always be mindful and do an exam for upper motor neuron signs. So Hoffman test is a quick hyperflexion or extension of the IP of the long finger, resulting in a compensatory flexion. Sorry, guys, of the IP of the thumb. Inverted brachioradialis, which is a really interesting reflex once you see it, and I think I have a video of it on the next one. Ankle clonus, so it's a abrupt ankle dorsiflexion resulting in a reflexive compensatory plantar flexion, and that can be multiple beats. So someone who's really myelopathic, people can have sustained clonus. So you flex their foot up and that clonus, their feet will bounce. One interesting thing you can do really with any of the surgeries is a patient's coming out of general anesthesia, you can do a ankle clonus test, and usually people have sustained clonus. So anyone coming out of GA will usually have sustained clonus. So if you guys want to do a little physical exam test, you can do that on any of your patients. So Babinski's stroking of the bottom of the plantar aspect of the foot, usually in kind of a C-type shape from the heel up to the first MTP joint, and it causes the normal response is a flexion of all toes, and a abnormal response is an extension of the great toe and a flaring of all the lesser toes. And then have them walk. So tandem gait, very helpful to elicit myelopathy. And remember, just because someone has arm pain, has arm weakness, has dermatomal distribution, doesn't mean they can't have a disc or an osteophyte that's pressing on both the nerve root and the spinal cord. So it's a very common condition called myeloradiculopathy. So it's not one or the other. It's radiculopathy and or myelopathy. So you always want to evaluate for the presence of either or both. They're not mutually exclusive. This is the Sperling's test. So there's really four components that we often don't talk about. So first, it's an extension of the neck, and then it's a lateral bending to the symptomatic side. And the idea is you're trying to pinch the neuroforamen on the symptomatic side. If the person is then symptomatic, and that's not neck pain, that's arm pain, it has to reproduce the radicular symptoms. You do not need to apply an axial load, but you can jump to the fourth step, which is providing manual cervical distraction, and that'll usually relieve their symptoms. If the first two maneuvers do not cause pain, you can apply an axial load, which can further encroach the frame and then do the fourth maneuver. We often kind of do the first two, and they'll say, yeah, my arm hurts like that. Sometimes jamming on people's head isn't super well tolerated. This is a sign that I love and I feel is really, really specific. If someone comes in and they have their neck lean to the side and their arm up like this over top of their head, it's a really good sign of a hot cervical radiculopathy, because they're trying to reduce tension on their peripheral nerves that are tethered to their roots. So this is similar to the opposite of a straight leg raise in the lumbar spine. So whenever this person drops his arm, he has arm pain because there's tension. So they'll either do this, so the hand over the head, or they'll hold their arm and kind of hike their shoulder up. So those are the two ways people can look that come in with cervical radiculopathy. So you always want to know differential diagnosis. I spoke to this a little bit earlier. Think about peripheral compressive neuropathies. So carpal tunnel can look a lot like a C6 radiculopathy. Cubital tunnel can look like a C8 or a T1 radiculopathy. People can have a brachial plexopathy, particularly if they're diabetic. You can also get an acute inflammatory plexopathy called Parsonage-Turner syndrome. It's one of those things I kind of never thought of as a resident or fellow, but when you've seen it a couple times, it's pretty remarkable. People get acute severe pain about their shoulder girdle on the right, and then the pain kind of relents and they get proximal weakness. So if someone comes in with severe pain and their neck looks pretty normal, they may have inflammatory plexopathy, and the treatment for that's usually supportive. It usually gets better. Herpes, herpes, the zoster virus hides up in the dorsal root ganglion, so people can get burning pain and a dermatomal distribution. It's most commonly in the thoracic or abdominal region, so the thoracic nerve roots, but can happen anywhere. And then shoulder pathology, and it's not uncommon. You guys have seen us kind of hand people back and forth for shoulder versus neck, and it can be both. People can have a small cuff tear and some osteophytosis and foraminal stenosis. So it's good to not only get their history, but do the exam we spoke of. And don't forget the benefit of diagnostic injections. So quick subacromial or intra-articular injection in clinic, and people get 100% relief. You can really think that although they may have cervical pathology, that the shoulder may be playing a more predominant role. If they get no relief, you can send them for a cervical epidural. And then if they get relief from that injection, then the opposite is true. So this is a tough one, but it was in the review chapter, and it can be tested, determining the difference between cubital tunnel and a C8T1 radiculopathy. Remember that the ulnar nerve innervates all hand intrinsics but four, and you can remember this above the lull. So abductor pollicis brevis, opponens, flexor pollicis brevis, and the two lateral lumbricals. So the ulnar nerve provides sensation only to the ulnar border of the hand and the ring finger, whereas C8 and T1 provides additional sensation over to the medial forearm and via the medial antebrachiocutaneous nerve. So differential diagnosis, you want to take a history, you want to do a physical examination. Don't forget diagnostic injections. EMGs can be helpful, particularly with peripheral compressive neuropathies, because you can do conduction velocities across segments for cubital and carpal tunnel. Remember, you can't do conduction velocities for cervical nerve roots because you can't get before the foramen and after the foramen. So for cervical radiculopathies, you're really dependent on the EMG portion of the test and also paraspinal EMGs, which are of varying quality, particularly if someone's had a posterior cervical or a posterior spine surgery in the past, because it can denervate all those muscles anyways. And then MRI, CT myelogram. And sometimes MRI and CT are complementary tests. The MRI is good at showing the cord and the nerves and soft disc herniation. CT and CT myelogram are good for any osteophyte or bony component of stenosis. So we're still talking about cervical radiculopathy. Natural history is generally favorable, particularly with soft disc herniations. It's amazing how many people come in with terrible arm pain. They have a big cervical disc herniation. You do some exercise, you give them some anti-inflammatories, maybe an injection, and most of them get better. The vast majority get better. So the treatment I spoke of a little bit: therapy, traction, anti-inflammatories, either NSAIDs or steroids. Can do antineuropathics, gabapentin or Lyrica. Can do some manipulation. I don't like high velocity chiropractic manipulation. There have been some case series of vertebral artery dissection with such interventions or adjustments. Immobilization is way down on the list. We generally don't do it. I would not put people in a collar. Some people do a soft collar for a very short period, just try to calm things down, and then epidural steroid injections. Surgical treatment, obviously, if they have severe progressive deficits, or more common one is failure of non-surgical treatment. So usually we say 6 weeks of non-surgical treatment failure and severe symptoms. Someone can be a candidate for surgical intervention. Can either address this anterior or posteriorly. Anteriorly was traditionally with an ACDF, but total or cervical disc replacements become an increasingly acceptable and reasonable option. Or posteriorly, you can do a laminoplasty, posterior decompression, or a discectomy. So ACDF approach, you guys have both seen left side approaches with me and the other guys, and then a right side approach with Dr. Asanzada. They're equal in safety and efficacy. Traditionally, left side approaches have been quoted as a preferred reason due to the more predictable course of the recurrent laryngeal nerve. But again, multiple studies have shown there's no difference in nerve injury rates between left or right sided. So this is a soft disc herniation. You can see here, you might say, oh, there's not much stenosis, but this whole frame is filled with the disc herniation here. So this is the most common level 2, 3, 4, 5, 6. So it'd have C6 symptoms right there. And this is a beautiful parasagittal image showing that disc herniation right there. This patient got an ACDF. So anterior approach, clean out the disc, remove that disc herniation, block of bone, and then a plate. So cervical disc replacement, evidence suggests that adjacent level disease for an anterior cervical discectomy infusion is about 3%. So in attempts to maybe diminish or decrease the amount of symptomatic adjacent level disease, cervical disc or disc replacements were designed and developed. So this is posterior approaches, soft disc herniation. You can do a keyhole laminotomy. It's called a keyhole because there's a larger portion in the laminotomy portion and then a more narrow portion out in the foramen or facet portion. You identify the exiting nerve root. You retract the nerve root either superiorly, inferiorly, depending on where the disc is herniated. Usually you retract the root superiorly and you remove the disc herniation. Can be tough to find the root, find the disc herniation. So at least for our group, anterior-based procedures for soft disc herniations, a little bit more preferred, but please note that disc herniation, lateral disc herniation is completely reasonable to get posteriorly. One contraindication is as this disc herniation sneaks more medially because you can't retract the cord. No, that's what it says right here. I didn't even say. You can either do it seated or prone. Not a ton of people do them seated anymore, although some do. There is a risk of air embolus doing any seated cervical procedure, so that's a commonly tested item. And prone is what we do if we do a cervical foraminotomy or discectomy. Be certain not to take any more than 50% of the facet. Trying to move along here a little bit. So ACDF, obviously, it's direct removal of the anterior compression. It's a really elegant, muscle-sparing, minimally invasive approach. But you got to worry about where you get the graft from. Is it going to heal? Is the plate going to cause dysphagia? Posterior foraminotomy is nice, but it doesn't fuse the segment, and you may not be able to get the disc or complete ventral decompression. So both have risks and benefits. Surgical treatment in general, people do pretty well with these. Reported radicular relief of arm pain is 80 to 90%. So usually start with non-operative treatment if there's no red flags, no profound weakness or myelopathy, and you can do surgery if they fail. All right, final segment, we'll try to finish up. I'm sick of speaking. So myelopathy is compression of the spinal cord. They may or may not have neck pain. You really want to screen every spine patient that comes in, whether they come in for low back pain or myelopathic complaints, because it's not uncommon that people come in with neurogenic claudication, lumbar stenosis symptoms, and they're in a wheelchair, and then you find they're floridly hyperreflexive, and they're really in a wheelchair because of this large disc herniation or an osteophyte causing spinal cord compression. You want to ask about fine motor skills, so opening jars, counting change, buttoning buttons, handwriting, difficulty with gait. You know, do they say that their spouse says, you know, why are you walking like you're drunk, or, you know, walk straight, hand or foot numbness, bowel bladder problems, and often you can get concurrent radiculopathy. So this is some of the reflexes we talked about. That's a Hoffman's reflex on the upper right. That's an abnormal Babinski on the bottom right. See if this comes up here. I'm scared if they change this YouTube, but this was a good reverse radial reflex. Let's see here. So you do a brachioradialis reflex, and normally you'll have extension of the wrist, but you can see this patient has a compensatory flexion of the fingers and the wrist. So if you ever hear reverse radial reflex, I always got confused and like, oh, does that, you see something on the other hand, but it's that. And once you see it, it's, oh my golly, hold on. That was hilarious. I thought that was someone on our Zoom talking. I'm like, what the heck? Who's an osteopath from New Zealand talking on our Zoom meeting? That was crazy. So this is cervical myelopathy, just looking at physical exam signs. What this says is not all people with myelopathy have common signs, so Hoffman's Clonus, and not everyone with signs have myelopathy. So it's really challenging to just say, be vigilant. Like you can't say, boy, they sound really myelopathic by their history, but they don't have a Hoffman's and they don't have Clonus or they don't have a Babinski, because often people are old and they have an existent, coexistent peripheral neuropathy, either diabetic or just an idiopathic peripheral neuropathy, and it'll dampen out all those abnormal reflexes. Or a young, healthy female will have 3 beats of Clonus and a Hoffman's, and they're completely normal. So although we use the physical exam findings, you have to be mindful either way. You can see here, this is a patient of mine on the right, pretty clear spinal cord compression. And also you want to be kind of vigilant for looking for ossification of the posterior longitudinal ligament. You can see here, you might say, oh, well, this is just spondylosis and a disc herniation, but this is the same patient with a CT scan. This is why often if I'm doing myelopathy surgery with appearance of this, I'll get a CT scan, because although this may not change your intervention, it may inform your intervention. So there's a high incidence of dural atresia and dural thinning here. So if you go in and take this bone out, you may be looking at the ventral surface of the spinal cord. So it's not unheard of that we don't manage CSF leaks with OPLL, but it's something you want to know that you're going into before you get in there. And this patient may be a candidate for a posterior-based procedure. That way you stay away from this entirely. So either laminoplasty or laminectomy infusion. So it's another good reason. And it's part of the reason why a lot of posterior-based procedures were designed in Japan and China. Is a pretty high incidence of OPLL in Asian populations, and that's why they designed laminoplasty and a lot of posterior-based procedures. So myelopathy, you can have slow progression, you can have kind of stepwise decline, or a very small percentage will have really rapid progression. So they're doing fine, and then all of a sudden they're really having trouble walking or trouble getting out of bed. That's pretty common. Usually it's more of a slow progression. I noticed it 5 years ago and it's gotten worse each year. And now I'm walking with the cane. And people call it the silent functional killer just because people often don't have any pain associated with it. They just had decreased function. Treatment options. So if patients have spinal cord compression but no symptoms or signs, it's often reasonable to watch them. And a lot of good Japanese studies have shown a favorable natural history of observation of spinal cord compression. Sometimes we get tough watching it when it's really severe, but usually if they have severe cord compression but no myelopathic symptoms and signs, I'll just say I'll see you back in 6 months, but here's what to be vigilant for and just keep an eye on it. I got a lot of patients out, 5, 10 years who just been watching severe stenosis and they're absolutely asymptomatic. Non-surgical treatment really is limited. I mean, you don't use collars, usually don't do a ton of epidurals just because there's severe stenosis already, so you don't want to put you don't want to occupy the canal with more stuff. This is an important study from Failing's group, is that essentially people who have milder myelopathy and earlier intervention and are healthier and younger do better. So I use this study to say if you detect myelopathy, you usually want to do surgery earlier rather than saying, oh, well, let's just wait till it's really bad and then we can do it, because those patients do worse. So usually once we detect myelopathy, people have surgery. I'm running along here a little bit. So goals of treatment, we always tell patients that we're trying to halt progression. I usually never sell improvement, although oftentimes people will improve. Really severe compression, so critical cord compression, even with the most meticulous surgical intervention, people can wake up and be worse. So I always say, we're going to go in and take pressure off the spinal cord, but it is really a spinal cord at risk, and there's a small but reasonable chance that you could wake up worse, and that may or may not be positive. So it's not very common, but it can happen. Similar to a posterior approach, you can do ACDF or corpectomy, depending on where the compression is. You can do disc replacement, although it's a little bit more avant-garde as compared to a cervical radiculopathy. Posterior, unique to compression, you can do a laminoplasty. So essentially you cut the lamina completely on one side, incompletely on the other side, and you open the door and then hold the door open with these plates. You guys have probably seen this on one of our services. We do a fair number of these, or combined you can do front and back, and there's a place for all of them. You guys all know this. We'll finish up. And really people always ask, if I have a fusion in the front of the neck, does my motion decrease? And there's lots of studies showing that no, people don't have an appreciable decreased range of motion, particularly because you get most of your functional motion at the top of your neck. And this is just a pictorial of a laminoplasty. Remember, contraindication for laminoplasty, a pretty strong contraindication is significant kyphosis, but also neck pain, segmental instability. There's a lot of other relative contraindications, although we do tend to press indications for plasty here because we found that they do quite well for cord compression. And remember, posterior-based procedures are based on a posterior drift of the cord. And this is the technique for plasty. This is kind of pictures of what I described, intraoperative picture. Obviously, you don't want to do a laminectomy alone because it risks this condition, post-laminectomy kyphosis, which is a real pain to deal with. It's really more common in kids when they have an intradural tumor removed. It was common for our neurosurgical colleagues to do a big wide laminectomy, open up the dura, take out the tumor, and then just leave this in kids. And those kids almost get 100% rate of post-laminectomy kyphosis. You can see this as a kid. That's a challenging condition to deal with. So laminectomy and fusion, you take the whole lamina off, then you place these lateral mass screws. So these screws are in a mogral trajectory, so start in the mid portion of the lateral mass trajectory is cranial and laterally. So I think I took a long time. That's a lot of slides, a lot of stuff to get through. All right, guys. Hopefully you heard all that. If you didn't, I'm not repeating it. Anyone have any questions or
Someone talk to me so I know that you heard me. Hold on, I'm not hearing you.
We heard you, sir.
Oh, there we go.
Thank you.
Everyone take your phone off mute. Get out of the shower or stop drinking your cup of coffee. You guys, I ran pretty late. It's a long talk. Are you guys doing questions still, or are you not doing that anymore?
They still do that.
Okay.
I don't know if it would, Mike, who's got questions? Anybody?
I don't think questions were assigned on this talk.
Oh,
right.
man. That's how much you think is fine, huh? No questions. All right. I
Because
guess
we
we're
got all
done.
the answers already.
Yeah, exactly. I gave you all the answers. All right,
Thanks, Adam.
guys.
Thank
Yep.
you so much. That was awesome.
Yep. Have
Thank
a
you.
good morning. See
Thanks,
y'all.
Dr. Shimer.
Yep.